Hello, my name is Matt Strelo, and this is the third part in our section on the management and evaluation of burns. So let's get back to our case of our 10-year-old boy who had a scald burn from boiling hot water. The pre-hospital or very early care in this patient is going to be involving removing the clothing, removing any jewelry, especially constrictive jewelry over areas of a burn because they will swell. We wanted to keep it clean and cover with a clean, dry dressing. If it's a small burn in the pre-hospital or even early in the hospital management, you can use a clean, moist dressing. But if it's a larger burn, to avoid hypothermia, you should use dry dressings. As shown in this picture here, you also want to, when dressing the wound, separate any burned fingers or digits because they can stick together over time. The cornerstone of managing these patients is determining their IV fluid therapy because these patients lose a lot of fluid through their burned skin, and they're also hyperdynamic, so they're losing fluid because they're hyperdynamic as well. The patients that require, or it's recommended that they get IV fluid therapy, are patients with larger burns. So in adults, anyone with a burn greater than 20%, in children, anyone with a burn greater than 15%, and in infants, any infant with a burn greater than 10%. If there's any question about whether the patient should get IV fluid therapy, I would recommend giving IV fluid therapy. You can always back off later. Most people use the Parkland Formula because it's easy to remember when determining how much fluid a patient should get. The Parkland Formula says that the total fluid requirement in the first 24 hours after the burn is 4 mLs times the total body surface area in percent times the patient's weight in kilograms. This fluid is then divided in half, and half of that fluid is given in the first 8 hours, and the second half of that fluid is given over the next 16 hours. Be careful though, because the timing of fluid is not from the time that the patient arrives at your hospital or the time that the patient is seen in your ambulance, but it's from the time that the patient was initially burned. So oftentimes by the time we're first evaluating that patient, it's already been 1, 2, or even more hours since that burn. And when we're calculating when to give the fluids and how fast to give them, we should be calculating that from the time of the initial burn. So let's look at our case as an example. So in our patient, we estimated that the patient had about a 15% body surface area burn. This patient is about 30 kilos, okay? And we want to multiply that times, we're told by the Parkland Formula, 4 mLs. And so that's going to come out to a total fluid requirement over the first 24 hours of 1,800 milliliters. So we're going to divide that then in half and give 900 milliliters, okay, over the first 8 hours from the time of burn, and then the other 900 milliliters in the 16 hours that follow. What type of fluid is really less important? Typically we use crystalloid, and you do not need colloid in these patients early on. So you're going to use normal saline or lactated ringers. Most people use lactated ringers if it is available in these patients. Now, in children, you have to add the maintenance fluids to your IV fluid calculation with the Parkland Formula. In adults, we tend not to do this. So in our child, we want to add maintenance fluids to that fluid calculation we did. So the patient's 30 kilos. So if they're 30 kilos, I like to use the 4, 2, 1 rule. So in the 4-2-1 rule, that says for the first 10 kilos of the patient's weight, we're going to give 4 mLs per kilo per hour. So that's going to be 40 mLs per hour. For the next 10 kilos, we're going to use 2, so that's 20. And for all of them after that, we're going to use 1. So this patient being 30 kilograms, we're going to use 70 mLs per hour is this patient's maintenance fluids. So we're going to add that then to our Parkland formula calculation. So our Parkland formula calculation told us that we wanted 900 mLs in the first 8 hours. So 900 mLs in the first 8 hours is going to be 112.5 mLs per hour. That then we're going to add our maintenance fluid, so plus 70, right? So our IV fluid rate, assuming that the patient was burned immediately at the time we saw them, which is not the case, so we'd have to make a slight adjustment for that, would be 182.5 mLs per hour of lactated ringers or potentially normal saline. So as you can see, this is a very high fluid rate. And in actuality, traditionally, we have under-fluid resuscitated patients, especially our pediatric patients. So we want to be aggressive with these patients' fluid resuscitation. Now, in the more modern era, when people are using the Parkland formula, we actually find that we are over-fluid resuscitating some people, especially some of our adults. So although the Parkland formula is a nice place to start, we do want to then begin monitoring things like the patient's urine output and adjust over time. If the patient has a urine output of 0.5 to 1 mLs per kilo per hour and there's no signs of rhabdomyolysis, in that case you might be able to back off the fluid and go at a slightly lower rate. But the Parkland formula is a nice place to start, and then as an inpatient they can monitor the patient's urine output and other vital signs and determine if they can either need to increase or decrease that fluid rate. Additional therapy is management of blisters, which is a very common question. As a general rule, if the skin is intact, like you have in a blister that's not ruptured, you want to leave that skin intact because that is protecting it from infection. Now in a very large, tense blister, which you're confident is going to rupture, especially if you're going to send that patient out, you might debride that blister prophylactically before it ruptures to make sure that you can get that area cleaned well and then dressed well. You also want to administer tetanus prophylaxis if the patient is not up to date. Especially in children, you want to monitor their glucose level because they're at a high risk for hypoglycemia if they have a significant burn due to their low glycogen stores. Okay, and add glucose to the IV fluids as needed if their glucose does drift low. And then you want to clean the wounds with gentle cleaning of soap and water about 2 times daily. What about antibiotics or topical antibiotics? So for non-superficial depth wounds, so all of our partial and full thickness wounds, we typically give topical antibiotics. And we don't always do this initially in the emergency department. We might just keep the patient clean until they can get seen by the burn specialist. But anybody that you're going to send out, or anybody where there's going to be some delay, we want to clean that area and then apply a topical antibiotic. The most common antibiotic used are antibiotics that contain silver or silver compounds. Sometimes these are impregnated into the gauze themselves, but still, as far as the topical solutions go, silver sulfadiazine or Silvadene is by far the most commonly used medication. You have to be careful though to avoid using silver-containing products or silver sulfadiazine in pregnancy, in newborns because they might absorb too much through their skin, in nursing mothers, and in anyone with G6PD deficiency. Additionally, you want to avoid the use of silver-containing products on the face because they can cause permanent staining to the skin. So if you're not going to use Silvadene, another option would be to use bacitracin. Now, bacitracin or other topical antibiotics are okay, but you should avoid the prolonged use of neomycin-containing products because of contact sensitivity developing in many patients. So where do these patients need to go? Which patients can go home, and which patients need to get admitted or go to a burn center? We typically try to classify patients into 3 different categories: those with minor injury, moderate injury, or major burns. Minor injury burns are those with a less than 10% body surface area burn in an adult that's either partial thickness, not full or deep. Okay? Frequently it's hard to determine if it's deep partial thickness or full thickness in the emergency department. So if you are unsure in the initial evaluation, it's better to err on the side of calling it deeper, keeping the patient in the hospital to get a better assessment of that patient's burn depth. Other patients that may be able to go home are those with a less than 5% total body surface area in younger patients, or a less than 2% full thickness burn. Now, our patient was approximately 15%, so that patient definitely doesn't fall into our minor burn category, and that patient is going to need to come into the hospital. In a patient with any kind of major burn, greater than 10% in a young child like we had, or greater than 20% in an adult, those patients we want to get to a burn center if possible. So you're going to stabilize those patients, contact the burn center, and try to get them to a burn center in a reasonable fashion if they're stable for the transportation. Other patients that are going to be high risk are those with electrical burns, those that have burns that cross joints, those that have burns in sensitive areas like the hands, the face, the genitalia, and or those with inhalational injury. All of those patients we want to get to a burn center sooner rather than later if possible, but otherwise at least get them admitted to the hospital. What do we do about treatment for possible carbon monoxide poisoning? Well, the cornerstone of treatment is really high flow oxygen. So we want to put these patients on a non-rebreather face mask. If we intubate them or they need to require more extensive airway management, we're going to put them on 100% FiO2. And we're going to monitor these patients then for signs of ischemia or acidosis. Why do we use oxygen therapy in patients with carbon monoxide poisoning? Well, high flow oxygen therapy decreases the half-life of the carbon monoxide. So the carbon monoxide is more likely going to come off of the hemoglobin molecule and then be replaced by a normal oxygen molecule rather than the carbon monoxide molecule if we give high flow oxygen. So at room air, the half-life of carbon monoxide is about 4 to 8 hours. If you put the patient on 100% FiO2, you can decrease that half-life of the carbon monoxide all the way down to about an hour or 40 to 80 minutes. If the patient has significant neurologic symptoms, altered mental status, seizures, or if the patient is at very high risk, such as a pregnant patient, and you have access to a hyperbaric chamber, you might consider sending that patient for hyperbaric oxygen therapy, which can decrease the half-life of the carbon monoxide to 15 to 30 minutes. A hyperbaric chamber is frequently not used, though, in our burn patients when we have multiple things going on, as it might be quite difficult to get that patient successfully stabilized into a hyperbaric chamber in a time frame that would really make a difference. The treatment of cyanide poisoning is high flow oxygen as well, but if we do have a suspicion for cyanide poisoning, and it can be quite difficult to diagnose, but if you have a patient who has cherry red skin, a concerning history, some neurologic abnormalities, or potentially an unexplained gap or lactic acidosis, which is what cyanide poisoning is going to cause, then in those patients, you're going to want to administer hydroxycobalamin and sodium thiosulfate. If you do not have both of these agents, you may only have sodium thiosulfate, you can administer sodium thiosulfate. In a burn patient, though, administering the amyl or sodium nitrite is not recommended. So in contrast to someone who has just a cyanide poisoning and no burn, where you might use nitrites in combination with the sodium thiosulfate, you will not do that in your burn patient. Remember, the symptoms, though, from a toxic fume exposure, such as carbon monoxide or cyanide, can be delayed. So if the patient has a significant burn and a concerning history, it's better to treat these patients with the high-flow oxygen and potentially empirically treat them as well for cyanide poisoning, even if the symptoms don't suggest a significant poisoning initially. So let's go back to our case then and summarize our patient. We had our 10-year-old boy who had a scald burn from water while the mother was cooking and dropped the pot. We estimated the patient's burn area to be about 15% of partial thickness burns, probably a combination of superficial and deep partial thickness burns, as the patient was having significant pain, but there also was some patchy appearance to the burn area. In this patient, we decided this patient was a moderate to severe burn and probably needed aggressive management of their burn, including IV placement and aggressive IV fluid resuscitation therapy. And we calculated out a high rate of IV fluid therapy because we added in the maintenance fluids in a child. So we were initially starting at a rate of about 180 milliliters per hour of lactated ringers. Normal saline was another alternative in this patient. We're going to give aggressive pain control as well. We looked and there was no evidence of an airway burn, and because it's a scald burn, we're not worried about carbon monoxide or cyanide toxicity. So it's mainly a management of fluid therapy, pain control, and then cleaning the wound and applying a clean dressing with topical antibiotics. You might use a silvadene or silver-containing compound or a bacitracin in this patient. And then we always think about other injuries and non-accidental trauma. Was this a case where the patient was burned intentionally? It's always difficult to tell, but you need to have a high level of suspicion and make sure you take time to evaluate children with burns and elderly patients with burns, looking for signs that it's symmetrical burn, such as a symmetrical burn of the buttocks area or the feet. In this case, the history makes sense that the mother may have dropped this water on the patient, and it would have a distribution similar to this. So in this patient, we don't have a high risk of concern, but it's something we should keep in the back of the mind, our mind while we're caring for this patient, and look for other evidence of injury on this patient when we're looking at them or in the family members. So in summary, we had the opportunity to care for this patient, and this patient actually did very well with that. And we got the patient to a burn center where they can do appropriate management of the burn and potentially skin grafting if necessary, and the patient's burns were deep partial thickness or full thickness. Thank you for your time, and that's the end of our burn management lecture.